This is Jurgen Futter. I'm a radiologist and specialized in prostate MRI. This workshop is about MR imaging of the prostate. And the first 10 minutes, I will discuss the theory behind the MRI of the prostate. And the last 20 minutes, I will spend on cases in which MRI is being used to detect prostate cancer. In 2019, the European Association of Urology guidelines were changed and adapted because the evidence for prostate MRI has evolved. And in this guideline, it's stated that MRI should be done before the biopsy, both for patients who are biopsy naive, so hadn't had prostate biopsy before, but also in patients with a prior negative biopsy. They should undergo MRI first. And this is based on the evidence which is provided by 4 level 1A papers. Because of the time, I'll not go in too much detail, but in all those papers, it was shown that MRI has a benefit over using the standard pathway, and the standard pathway includes PSA measurement and taking 12 to 14 biopsies of the prostate in a blindly fashion. Whereas if you implement MRI before the biopsy, you can perform a target biopsy, so that will result in less biopsy course taken. And it will yield in that the insignificant cancers are lower compared to the standard pathway. And also the number of significant cancers are increased in the MRI pathway compared to the standard pathway. And that will result, or this resulted, that the number of MP-MRIs are increasing in number. And also what you see in our clinical practice and daily routine is that the number of MRIs of the prostate are really increasing. So what is MP-MRI of the prostate? At present, it includes T2-weighted imaging, which is the cornerstone of MR of the prostate. It provides information about the tissue structure, cell density, by diffusion-weighted imaging, in my opinion, the most important sequence to find lesions within the prostate, and vascularity by means of dynamic contrast enhanced MRI. If you look at the guidelines for acquisition, which is provided by the PIRATE Steering Committee, this is the PIRATE version 2 in 2015. 2 years ago, it was updated to version 2.1. They recommend that the local prostate MRI should take less than 30 minutes, obtaining axial and a sagittal plane 42, that takes around 9 minutes. You can obtain 3 orientations but that also will influence the duration of your scan. Acquire diffusion-weighted imaging axial with the same slice orientation as a T2-weighted axial and the same slice thickness. The B values range from 50 to 800, and you should have a high B value above 1400. Then as a final step of the protocol, dynamic contrast enhanced MRI. There should be a gradient echo sequence with a temporal resolution covering the entire prostate less than 15 seconds for a duration of at least 90 seconds. So PIRATE version 2.1 was recently introduced. There was an update. And the reason why we introduced PIRATE is because we want to speak the same language, not only between radiologists, but also between urologists and radiation oncologists, that they understand what the meaning is of a lesion, for example, in the left peripheral zone, which is close to the capsule and has a certain size, that there's a kind of likelihood that this lesion is also a significant cancer. 2019, the update was being published in European Urology. And for today, I will use that as the background for the cases. So each lesion is assigned a PIRATE assessment category using a 5-point scale on the likelihood of probability that a lesion or finding on T2, diffusion, and DCE correlates with the presence of a clinical significant cancer at a particular location. So it's ranging from 1 to 5, 1 and 2, clinical significant cancers, unlikely or highly unlikely to be present at that location. And a pirates 4 or 5, clinical significant cancers likely or highly likely to be present at that particular location based on the imaging findings. So what is MRI clinical significant? Because if you look at in the literature, there's a lot of discussion, a lot of definitions being applied for clinical significant prostate cancer. In PIRES version 2.1, there's this chosen for Gleason grade 2 or higher, including 3+4, with prominent but not predominant 4 component, and or a volume of 0.5 cc, and or extraprostatic extension. So in case if you see real extraprostatic extension, by definition, it's a clinical significant cancer, and by definition, it's a PIRES 5 lesion. There are also different weightings for the different zones within the prostate. We have the peripheral zone and the transition zone. So diffusion weight imaging is the dominant sequence in the peripheral zone. T2 weight imaging dominates the transition zone, is the most important sequence. And also the role of DC is really limited within the scoring system of PIRES version 2.1. And you have to remember PIRES version 2.1 or PIRES is being applied in patients who are not diagnosed with prostate cancer yet, or who didn't undergo any treatment for the prostate. So it's really for the prostate naive patients, so biopsy naive patients, or patients with a clinical significant with suspicion of clinical significant cancer. So we also need some simple algorithms and tables to determine the overall score. So what they did is that they provided for diffusion, which applies for both the inner part and the outer part of the prostate, the transition zone and the peripheral zone, a 5-point scale. So for example, a 1 on diffusion is no abnormality, and a 5 is that you have a large lesion more than 1.5 cm and greater dimension, with hyperintensity on the ADC and hyperintensity on the IB value. I will show that in some examples in my next slides. As an example of a normal no abnormality in the peripheral zone or in transition zone, on the ADC map, which is located on the left-hand side, in the peripheral zone, which is located over here, there's no abnormality visible. Also in the high video, there's no abnormality visible. The inner part of the prostate doesn't show any abnormalities. Perhaps some slight increase in signal intensity in this part of the transition zone, and some decreased signal intensity in this part of the transition zone. Very important, if you look at the central part of the peripheral zone, there's always a pitfall. If you're at the level of the verum maternum up to the seminal vesicles, so at the base and mid part of the prostate, you always have the electrolytic ducts, which can mimic prostate cancer, but you always have to correlate your diffusion weight imaging with your T2 image to get the anatomical borders and landmarks. So dynamic contrast in MRI, also morphological descriptors. It's positive if you have a focal and early enhancing area, and also should also correspond to a suspicious finding on T2 or diffusion. DC is negative if it doesn't correspond to a focal finding on T2 or diffusion. I will show that also in my examples. Wat wil je in Britspond? So you also have to be careful that focal enhancement is also seen at features of VPH on T2. I will go through that in my cases. So the next 2 slides are the really most important slides of my presentation. So we have the PIRES assessment category. And this is the PIRES 1 to 5. For the peripheral zone, there's a PIRES assessment category, and for the transition zone. So if the lesion is located in the peripheral zone, then we go down this pathway. If it's located in the transition zone, then we go down this pathway. So for example, for the peripheral zone, as mentioned before, the diffusion weighted imaging sequence, or DWI, is the most important sequence to assess lesions within the peripheral zone. So that's a dominant sequence. So if you have a diffusion where the imaging shows an abnormality with a score of 1, so no abnormality, or a score of 2, some slight abnormalities, it will result in a priority 1 or 2 lesion. 4 and 5 the same, so 4 stays of 4 and 5 stays of 5. However, if it's indeterminate, based on a score of 3 in the diffusion with imaging, and it enhances on the contrast enhanced MRI at the same location, then a Pirate 3 can be upgraded to a Pirate 4 in case of a positive finding on dynamic contrast enhanced MRI. This is something you really have to remember. For the transition zone in Pirate version 2.1, and the T2 weighted imaging sequence is the most important sequence. So a score of 1 will stay a score of 1 on T2 in the transition zone, and a score of 4 or 5 will also not be altered. However, if you have a score of 2 on T2 and the diffusion weighted imaging shows a 4 or higher, then it's upgraded to a Pirate 3. If the T2 imaging shows a score of 3 in the transition zone, then DWI of 5 can alter the Pirate score, the final Pirate score, to a 4. So this is really important information. So it also will influence the scoring of the transition zone. So T2 is the dominant sequence, and DWI can alter the final Pirate assessment category based on the initial T2W sequence findings. I will show that in my cases. So this was a very small and brief introduction in Pirates and in the interpretation of prostate MRI. And in the next 20 minutes, I will show you some cases and go through some cases which are just day-to-day cases to show you how we can use Pirates in our daily routine. This is a 63-year-old male with a PSA of 6, stage T0. Patient had a 1 negative TRUST biopsy session of 12 biopsy course 1 year ago. And the prostate volume on MRI is 46 cc, and the PSA density is 0.13. I always use PSA density because that's, in my opinion, very important, because in patients with a Pirate 3 lesion and a low PSA density less than 0.1, the chance that the biopsy will be positive is very, very low. So that's being used in our decision model in patients with Pirate 3 lesions, which of the patients you should biopsy and which of the patients you shouldn't biopsy. So first of all, I will show you the images. I will leave you some time to look at the images and to make your interpretation. So on the left-hand side, the upper image shows you a T2 weighted image. Right next to that, the contrast enhanced MRI with the early enhancement, ADC map, and the high B value. And in general, when I start reading with the MRI of the prostate, I always start with the T2, get the information about the prostate itself, look at around the prostate, not diving into the prostate. For example, look at bladder polyps, rectal cancer, lymph nodes. Those can be found quite easily in patients with prostate cancer. And also lymph nodes are very important. So I'll leave you 10 seconds and you can have a look at it. So if you go back to the T2, I think that's the cornerstone of MRI of the prostate. So it reflects there's the different zones. We have the peripheral zone, which is located over here. It's the outer part. Then the inner part, we have the transition zone with a lot of nodules within the prostate, which resembles the BPH, benign prostatic hyperplasia, which also will cause the urinary problems lower urinary tract symptoms. At the center here of the peripheral zone, we have a uticular cyst, which is seen in 5% of the patients. But if you look closer, then it's quite obvious that the peripheral zone is almost similar in appearance of grayscale compared to the transition zone. And if you look closer, then it looks like that we have a capsule over here, and this is disrupted, and a large lesion is growing outside the prostate. And if we go to the corresponding diffusion and ADC map and diffusion image, then you can appreciate there's impeded diffusion and a high signal to IB value. But as mentioned before, if you see clear extension through the capsule into the periprostatic fat, it is by definition Pirates 5 lesion. My question to you is, do you see another lesion within the prostate, which we should assign a Pirates category? If we look closer then on the right-hand side in the right peripheral zone, there is some T2 abnormality. However, it's not confluent. It shows early enhancement. Diffusion shows somewhat impeded diffusion, but not really convincing. And the high B value shows somewhat high signal intensity, but also not really convincing, to be honest. And these are always difficult cases because on the Pirate score in peripheral zone, the diffusion is the most important sequence. And if you go back to the assessment categories, then we can see that the diffusion is a dominant sequence in the peripheral zone. And for diffusion, if you have a non-focal hypertension on ADC and non-focal hypertensity on a high B value, then it's a 2. So if you go back to the case, then we can assign this case as a Pirates 2 lesion. So we have 2 lesions, Pirates 2 in the right peripheral zone and a Pirates 5 lesion in the left peripheral zone with clear extension through the capsule. So we did an inbore biopsy on both lesions. Lesion 1 in the peripheral zone on the left side, we found a Gleason 9. And in lesion 2 in the right peripheral zone, inflammation or prostatitis was being seen and some scar tissue. So the teaching point of this case is that a case of peripheral zone cancer with clear extracapsular extension, this is not a case which we see every day, and a Pirates 3 lesion, and that's what the discussion is about. So you can either read it as some mild hyperdensity on diffusion, and some on an ADC map, and some high intensity on IB value. And that's still there's quite some inter-observed variability, which has been shown by the NYU group. So it can be quite cumbersome to assign a Pirates category score to these kind of lesions. Another case. This is a 70-year-old male, PSA of 18, 1 negative thrust biopsy session. The volume is 66. And the PS density is quite high, 0.27. The normal cutoff value urologist is using is 0.15. So my question to you is find a cancer, because there should be a cancer because the PSA density is really high. This is T2. Actual image. We have nicely the peripheral zone here. It's the inner part with a lot of large nodules. And we have the urethra over here. This T2. Then we on the right-hand side, in the upper corner, we have the contrast enhanced MRI. We have the diffusion, and we have ADC map and the high B value. So go back to the T2. And based on the T2, my question to you is, can you find, is there a lesion and where is the lesion located? So now I'll give you more information. And probably most of you already saw that, but if you look at the ADC map and the IB value, your eyes are drawn to this particular location, which shows impeded diffusion and high signal IB value. And if you go to the corresponding location on T2, there's a kind of lenticular shaped area over here, which also shows early enhancement. But because of the location, and we can discuss it's a peripheral zone or transition zone. If it's transition zone, T2 is the most important sequence. But if it's located in the peripheral zone, the diffusion is a dominant. But in both sequences, you can appreciate the abnormality. MRI transfusion biopsy showed at least 7 in this particular case. So if you look at this tumor, it is a lenticular shape. This is typical for a transition zone tumor. It's also not respecting the organized chaos of VPH. I will show that in a second. And it has also intermediate signal intensity, the erased charcoal sign. So if we go back to the T2, T2 is a dominant sequence in the transition zone. Those are the nodules. But if you look closely, then you can appreciate the hyperintensity, which goes through the anterior horn of the peripheral zone, doesn't respect the borders. So this is a typical lenticular anterior lesion in the transition zone, and which can be easily missed because it can be mistaken for the anterior fibromuscular stroma, which is also located in the anterior part of the prostate. However, this will never show impeded diffusion or show contrast uptake. Those two techniques will really help you to differentiate between anterior fibromuscular stroma and a cancerous lesion. Another case. This is a 71-year-old male, PSA of 8, had no previous TRUS biopsy sessions in his medical history. And the patient comes in with actual T2. And I'll leave you 10 seconds with his case. And these cases are picked by just daily routine. I've just picked one day and picked those cases. They're not selected. So this is the average quality we get in my institution. And so T2, so my question to you is the tumor located in a peripheral zone or in transition zone? In my opinion, it's very difficult to say that based on T2. So let's turn on some lights. And then the diffusion really helps you to locate the lesion, which is located anteriorly in the transition zone, which with impeded diffusion, high IB value, also a lot of uptake of contrast in this area. And if we look at the coronal image and sagittal image, you can clearly see there's a lesion located over here. My question to you is it the cancer or is it BPH? And it can be very difficult because in that case, you always have to look at 3 orientations. But because it could be that on the axial image, you just see one part of the lesion. And in this case, we don't really see a capsule around the lesion. But if you look in a different orientation, you may find some capsule around a particular lesion, as you can see over here. Gleason 7 cancer. So based on the imaging, and I know the transition zone is the most difficult area to assess lesions within the prostate. It can be quite cumbersome. So if you doubt, and that's something also what I did when I started with prostate MRI, I always got feedback from the pathologist. I always correlate biopsy findings with my MRI findings. In this way, you get a reference set, reference images. Also, it builds your confidence that certain lesions have certain imaging findings, which correlates with certain biopsy findings. So you need a kind of reference database in your head to assess those cases. Privates will help you to formulate what kind of lesion it could be. But pirates, I always say it's a kind of it's a kind of way to help you to assess lesions. But I always say you still have to use your brain, because the MRI is just part of the puzzle. You have to look at PSA, you have to look at PSA in time, PSA density, patient history. Is there genetic? A lot of things have to be taken into account if you interpret MRI of the prostate. So transition zone tumors can be challenging, as mentioned before. Look at it all, T2 imaging, DWI, B1400 can help you to focus to a particular area. Another case, 70-year-old male, PSA of 10, no previous TRUS biopsy session, volume of 85 cc, or a larger prostate. In general, prostate volume is around 50 to 60 cc, and the PSA density of 0.12. And this is a more difficult case. This is a more advanced case. So if we look at the T2, it's really smudgy here in the peripheral zone on both sides. Again, a lot of BPH nodules, which compresses the peripheral zone, so that it's really hard to assess the peripheral zone. And a lot of nodules in the transition zone. So if we look at the diffusion and the high B value and perfusion, then something attracts my eyes. So if you look closely in the T2, there's some hypointense area well defined in the peripheral zone on the right side. It also, because of diffusion, the most dominant sequence in the peripheral zone, it also shows high signal intensity or increased signal intensity on the high B value. And in P diffusion, so it's more compressed lesion. And also on the perfusion shows early enhancement. However, it doesn't influence the Paris assessment category, but it helps you to make your diagnosis. Gleason 7 was found on the biopsy. And if we look closer again, it looks like a flat tumor. And the flat tumors are quite often overlooked by during the reading process. Because we're not used to look at flat tumors in prostate cancer. Most often there are confluent, roundish lesions, but in this case, it's a really flat lesion, and those flat lesions tend to be overlooked and can also be very aggressive. So we really look at the capsule, and if the PSA is really increased or increasing, and you cannot find something, look again at the peripheral zone. Correlate your diffusion with your T2, and also contrast can help you then in that matter to find that particular lesion. The final case for today, because of the time, 60-year-old male, PSA of 19, one negative TRUS biopsy session, a large prostate of almost 100 cc, and a PSA density of 0.19. So there should be a cancer, isn't it? Because the PSA density is really, really high. T2 actual, again, there's an asymmetry in the peripheral zone. Left side is much larger than the right side, and there's a lot of BPH again, which is chaotic. It also helps us to define that most likely it's benign. The perfusion and diffusion, to be honest, there is some abnormality. It looks some slight abnormality over here, and also on the high B value, some increased signal intensity. But it doesn't correspond to a confluent lesion or isointense lesion. If you look at the transition zone, there are some abnormalities, but most likely it's BPH nodule. But the more striking lesion is over here. It corresponds with chronic inflammation and chronic prostatitis. Slightly lower signal intensity on T2, less restriction on ADC, but also what you see is that it has some decreased volume compared to the other side. So because it's chronic, it's not actively inflamed, it's atrophy, which contributes to the shrinkage on that particular site. And with that, I want to thank you for your time. And I hope that although it was virtual, that I could teach you something about prostate MRI. Thank you for your attention.
Hello, everyone. It's my great pleasure to have this chance to share with you our experience on the diagnosis of uterus and ovaries malignancies, imaging diagnosis, especially in CT and MR area. So this is today's outline. I'd like to share at least 6 points with you in this area. Based on the global cancer statistics in 2020, we know that the 3 most common female cancers, the cervical cancer, the endometrial cancer, and the ovarian cancer, ranked in the top 10 most highly incidenced malignant cancer globally. And also for the mortality, both the cervical cancer and also the ovarian cancer ranked in the top 10 as well. And so it is very crucial for us to understand, to know the imaging behavior of all these 3 different cancers. As for the WHO classification for these cancers, we see in the below the 2 lists. The cervical cancer can have not only the squamous cell cancer, but also adenocarcinoma, and also other different special and rare types. For the corpus cancer, the corpus carcinoma, we also have different kinds besides the endometrioid carcinoma. And for ovarian cancer, we all know that there's several well-known carcinoma, including these the cereals, the mucinous, and also the endometrioid tumors, and so on. And so for all these different types of malignancies, we have several imaging tools to do the evaluation: ultrasound, CT, MR, PET-CT. Well, in this table, we see that for the uterus malignancies, MRI actually play the most important role. It is the mandatory initial workup for the uterus malignancies. Well, CT will provide additional information for the uterus malignancy. Well, for ovarian malignancy, CT has the crucial role for systemic staging and so on. Well, MRI will provide additional information for local behavior and features due to the high soft tissue resolution. Well, ultrasound and PET-CT, one is the optional, the choice of option, and the other one can be useful for staging lymph nodes and detection of distant metastasis, as well as tumor recurrence. And so to have a small summary, CT and MR each have different indications. We see MR due to the excellent soft tissue resolution, so it is very useful for the characterization of pelvic masses. It is also useful for staging of pelvic malignancies, and also treatment, follow-up, and local lymph nodes evaluation. While CT is useful for systemic staging, the follow-up evaluation, assessing of the post-operative complications, as well as the such as the radiation therapy guidance and other procedural guidance. And so let's look into the protocol for different entities. And so for the ovarian malignancies, CT should be performed from the entire chest to abdomen to pelvis. And also contrast enhanced CT is the preferred imaging tool for the systemic staging of ovarian cancer. These recommendations are from both NCCN and from ACR as well. For the abdominal and pelvic CT scanning, intravenous contrast media is mandatory. Especially exceptional cases should be the contraindications. Well, at least one venous phase should be acquired 70 seconds after injection of the contrast media. Well, the scope, as we mentioned, should be from the chest to the pelvic, and 1 millimeter to 2 millimeter thickness, means thin thickness image is recommended. And if we do reconstruction for coronal and sagittal, 3 to 5 millimeter can be used. For uterus, it is also useful and recommended by the guidance that contrast enhanced CT should be used. The reason why is because it is useful for the identification of vascular structures and the soft tissue metastasis, and also it is helpful for to distinguish lymph nodes from small bowel loops and maybe sometimes vessels. As for the MR protocol for cervical cancer, compared with other cancers, with other female malignancies, it's somewhat different. T2 weighted imaging is the mainstay for cervical cancer detection. So, axial T2, sagittal, and the coronal T2 should be performed at least. And so, when saying that sagittal and the coronal and the axial, actually, axial and the coronal is oblique to the whole pelvic, but is absolute axial and coronal to the targeted area, so-called the cervix. If we are focused on the corpus of the uterus, and then the coronal should be the slides should be parallel to the corpus of the uterus. Otherwise, it should be parallel to the cervix of the uterus. For the endometrial cancer MRI protocol, there are three important sequences that we need to mention. T2 weighted is very important as well, but we should not use a fat sat sequence because we need the fat to be the background, to be the contrast to see the malignancies. Well, DWI is useful for detection of extrauterine lesions, and relatively higher B value is recommended as 800 to 1000. So contrast enhanced imaging is useful for the evaluation of the depths of myometrium invasion, because we all know that the endometrium cancer is hypo-enhanced in the contrast enhanced image compared with the myometrium. And so contrast enhanced image together with the T2 weighted image can be very helpful to evaluate the scale of the invasion. And for ovaries, it's different. The MRI protocol for ovaries, both T2 and T1 weighted imaging are crucial because they are together helpful for identification of the different components of the tumor, and so as for the help of the differential diagnosis. Some example. So T2 plus T1, we can tell the cystic component, the solid component, the hemorrhage component, the fat, and so on. And so in this list, I give several examples, such as the serous cyst adenocarcinoma. We see the cystic component as well as the solid component, and with the intermediate to low T1 weighted T1 signal intensity. And for the endometrial carcinoma, we see the hemorrhage component, which is quite helpful for the differential diagnosis. And for the granulosa cell tumor, it is commonly, usually it is solid, but sometimes the necrosis can be seen. So with T1 and T2, it is very helpful for us to see the difference. Talking about the functional sequence, we actually have several tools. We have DWI, we have DCE. And so with DWI, we have ADC, the semi-quantitative parameter. With DCE, we have the curve, we have the V and several parameters, and also actually APT and other several functional MRI sequence can be also used for clinical research, but for in the consensus, in the clinical guidelines and consensus, DWI and DCE is now are now included. And DWI is useful for small lesion detection, differential diagnosis, for the lymph node evaluation, radiation therapy planning, and also treatment response monitoring due to its semi-quantitative characteristic. And for DCE, the lesions qualitative diagnosis as well as semi-quantitative diagnosis can be done based on DCE, and also it can be used for treatment response monitoring. Well, before the examination, we have actually several recommendations for patient preparation, which can help to increase the image quality, including the intravenous antiperistaltic agent application injection to stop the movement of the bowels, fasting, and also sometimes the moderately filled bladder is recommended to help to push the uterus upper, and then to see more clearly the structure of the cervix as well as the vagina, and also sometimes the mucosa. I mean the bladder's mucosa. And so for the image anatomy of uterus and the ovaries, we see from these 4 different images, the left 2 are CTs, the right 2 are MRs. So from this, we can tell the excellent soft tissue resolution. And yes, here we see the cervix in the CT, but actually you cannot really see the myometrium, the fibrous stroma, and the endocervical canal. And so these are actually very helpful to help the diagnosis, the staging of the female malignancies. But with this image resolution, it is very hard for us to to do the above things. And here what we see is 2 ovaries, but what's inside is very difficult. But with MR T2 weighted imaging, we see the follicles, and we see the medulla, and also we see the cortex of the ovary, which is the surrounding low signal here. And also one thing to mention is with our previous study, we found that the menstrual cycle actually will have some effect on the image quality and the evaluation of some female diseases. These are somewhat similar as the ultrasound. We all know that when a patient are referred to the ultrasound department, actually they will wait for a special menstrual cycle. But MR, we usually don't recommend the patient to come in a very special phase. But with this study, we found that the margin of the junctional zone will be blurring during the menstrual phase, and also the thickness of the junctional zone in the menstrual phase will be the thickest. And so actually we need to think about the menstrual cycle, and such as the adenomyosis patient, we should stay in the same phase for the evaluation of the lesions and the scope. And so we now we talk about the cervical cancer, the fecal staging of cervical cancer. The newest one is released in 2018. And so with this fecal system, we can tell that actually the clinical requirement for a more accurate evaluation and measurement of the lesion is quite high. And so we all this size evaluation, as well as the para uterus organ invasion, such as the vagina, the pelvic wall, and also the ureter, and so on, and the lymph nodes. All these settings actually pointed to MR image. We truly need MR image to help the clinical to do the fecal staging for the cervical cancer, to give the patient the right way afterwards. So stage 1B, the definition of stage 1B is invasive carcinoma with measured deepest invasion, larger, no less than 5 millimeter. But the lesion should be limited in the cervix. And so here, the most important thing is the measurement of the lesion. And so this is 1B1 stage. The size of the lesion is very small, smaller than 2 centimeter. This is 1B2. See, the lesion is larger, but still smaller than 4 centimeter. This one, still limited in the cervix, but a big lesion, larger than 4 centimeter. This is 2A, 2B. So stage 2 means that the carcinoma invades beyond the uterus, but has not extended down to the lower third of the vagina or to the pelvic wall. And so 2A means the lesion is limited to the upper 2/3 of the vagina without perimetrium involvement. Well, so we see this one invade the vagina, but upper third. This one bigger than 4 centimeter, and so this is 2A2. This is 2B because of the perimetrium involvement clearly shown on the T2 weighted image. This sign is very, very important because we all know that if the patient is earlier, no later than 2A, and then the patient can be referred to surgery. If the patient is staged down to 2B or even further, and the patient should receive the radiation therapy first. And so this sign is very crucial. Stage 3, the carcinoma involved the lower third of the vagina, the lower third, such as this one, the left image. We see the lesion very large, and here down to the lower third. And so this is the 3A, and this is 3B. It can be optional, can be extended to the pelvic wall. It can be like this one, cause the obstruction of the ureter, and or the non-functioning kidney, or involve the pelvic or para-aortic lymph nodes. This is 3C. And so 3C, we see 3C1 and 3C2. 3C1 is the pelvic lymph nodes metastasis only, and 3C2 is para-aortic lymph nodes metastasis. Stage 4 means further extension of the lesion beyond the true pelvis here. And so this is 4A. This one is the invasion of the mucosa of the bladder, but either the bladder or the rectum mucosa invasion should be proved by the biopsy. Well, the 4A means to adjacent pelvic organs, which means the bladder or the rectum. 4B means spread to distant organs, like this patient with the liver metastasis. Okay, so now let's move on to endometrium cancer. Samely, it has fecal stage. Samely, it need MR evaluation. We see, for example, for 1A, 1B, evaluation from MR is very useful to answer the question whether it is 1A or it is 1B, because we can see the low signal loop of the junctional zone, whether it is intact or not, and we can see the invasion depth, whether it is up to 1/2 or not, half or not, and so on, like whether the low signal of the normal cervical stroma is disrupted, and to see whether it is invade the stroma or not, the cervical stroma or not. MRI evaluation for further stage 3, whether the lesion invade the uterine corpus or adnexus. MR evaluation for further whether there's enlarged lymph nodes. And so this is stage 1A and 1B. The left image is T2, middle one, T1, gadolinium enhanced. And so with this two image, we see the typical image feature of this endometrium cancer, a middle signal intensity on T2 and hypo-enhanced on T1 gadolinium enhancement. Well, and so because of the background, the enhancement of the myometrium, and so we see the invasion of the lesion, and then we can do the measurement of the depths of the invasion. And 1B, we see the lesion much further invaded the myometrium, and so this is 1B, deeper than the one half, the half. Stage 2, the cervical stroma is involved, but the tumor does not extend outside the uterus. And so we will see here, like we talked about the cervix just now, there should be an intact low signal rim of the stroma, the cervical stroma. But with this patient, we see the disruption of the low signal rim. And so this one, we can call it stromal invasion. And so the stage should be 2. Stage 3 means it can be either the serosal invasion or the ovarian invasion or the vaginal invasion or parametrial invasion, the same as the cervical cancer. And so again, we see the usefulness of the T2 weighted imaging and the T1 enhanced image. Moderately intermediate high T2 signal intensity compared with the myometrium, hypo-enhanced lesion compared with the enhancement of the myometrium. And so we can see clearly the scale of the lesion. Stage 3C and 4, lymph nodes for 3C. And stage 4 means further extensive invasion, similar as the cervical cancer, bladder or rectal mucosal invasion, or more distant metastasis, including the peritoneum implants and so on. And this one actually represent the peritoneum implants in the pelvic area. And for the ovarian malignancies, we just now we mentioned that there are several different types of malignancies of actually, but in on the MR imaging, we can differentiate it. We can classify it into 4 different types. One is unilocular, second multilocular, third cystic and solid, fourth solid, pure solid mass. And so from left to right, from benign to malignant. And so if we see a unilocular cystic mass in the ovarian area, first thing in our mind is benign. If we see a cystic and solid mass, first thing malignant or borderline malignant. Solid mass is very special. If the solid mass has a low signal intensity behavior on the T2 weighted image, and mostly it can be fibroma or Brenner tumor, and it can be benign or borderline. So, well, and also, and for this unilocular cystic mass, sometimes it can be tumor or even not tumor. And so be aware of all this signs. And also interesting things is this high signal intensity on T1 weighted image. If it is a unilocular cyst with a high T1 signal, and then we will think about the chocolate cyst, I think, mostly. But if it is a cystic and solid or solid mass with a T1 high, bright T1 signal intensity, and then we will think about the teratoma. But with fat set, you will tell whether it is fat or not. And we will think about the malignant tumor with hemorrhage mostly. These 4 are some typical tumors for the upper 4 different types of ovarian mass. The first one is unilocular cystic mass. So you will see a big, massive unilocular mass. Sometimes it can be the opposite, white on T1, black on T2, and so this is not actually a tumor. This is a endometriosis and chocolate cyst actually. And so this one is a multilocular cystic mass. So this is mucinous cyst adenoma. And we see the heterogeneous signal intensity both on T1 and on T2 weighted image, but no solid component. Well, this one, cystic, absolute. Heterogeneous, yes. And here we see some lower T2 weighted image. We see some lower T2 signal intensity here. And so with enhancement, it is confirmed as the solid component. And so the diagnosis of this case is serous cyst adenocarcinoma. The final one is a solid mass, but with necrosis inside. After the confirmation of the origination from the ovarian, so this is a granulosa cell tumor. The mass is solid. Solid mass on the ovarian area, in the ovarian area, is relatively rare, and so the classification can be relatively easier for us to do. Well, for the ovarian metastasis, the ovarian cancer, we all know that about 70 to 80% of the ovarian cancer, when they firstly admitted to the hospital, there are metastases already. Mostly are implants in the cavities. And so these are some typical signs for the implants. This one is the omentum cake. This is very famous. And this one is nodular shell-like implants surrounding the liver and surrounding the spleen. This is the diaphragm thickening. Sometimes it can be neglected because when we use the axial image, it's this is contiguous to the diaphragm and the liver, and so it can be hidden and can be neglected. And sometimes we can see the sigmoid muscle involvement, the diffuse mesenteric infiltration, and also sometimes the lymph nodes metastasis will up to the pericardiac area like this. And now let's move on to the cases. Case 1. This is a cervical cancer patient. The question is bladder mucosa disrupted by the cervical tumor? What's the arrow represent on the sagittal T2 weighted image here? Well, I hope you found the results. The correct answer is B. No, the mucosa of the bladder is intact. Well, what is that? It is bladder here. It is bladder wall edema. So this one we call it the bullous edema sign here. What is this? This is the reactive T2 hyperintense thickening of the urinary bladder mucosa. However, if you look into each layer of the bladder wall, you will see there's no disruption of the low signal wall. And so this this actually recommend a intact mucosa. But what is this? What is this? This is a T2 weighted image, but after intravenous contrast. Because of the low signal intensity gadolinium in the bladder. And so we can see this white line which actually represent the reactive urinary bladder wall edema. And so this is very helpful, and this is called the bullous edema sign. Case 2. This is also a cervical cancer. And so what is this white arrow pointed to? And what do you think the figure of the patient is? Do you find the right answer? So the arrow points actually to the left ureter, and the patient therefore should be staged as figure 3B. This one, if we see, this one is an axial T2 image. This one is a coronal T2 image. And so that one arise from the pelvic to the abdomen. And so this is the left ureter, and a enlarged left ureter, a obstructed ureter. And so according to the fecal system, the patient should be placed into 3B. Case 3. So see these 3 images, what would be the diagnosis, and what is the fecal stage for this patient, you think? The left one is T2, middle one T2, right one T1 gadolinium enhanced. Be aware the star and the arrow. Okay. So now answer time. The lesion actually originated from the corpus. Well, yes, we have an arrow pointed to the cervix, but this is actually the endometrium of the cervix. This is not the lesion. This is a normal structure. So don't be fooled by this hyper intense area on the T2 weighted image. And so from the right image, we will see the very light invasion into the myometrium. And so this is a endometrium carcinoma with stage 1A. Case 4. What are the figures? So these 4 images are from 4 different patients: patient A, patient B, patient C, and patient D. And so these are all cervical cancers. And so can you tell the figure for this 4 patient? And then focus on the black arrow. What do you think this black arrow pointed to? Okay, answer time. The answer should be the first 2 patients are 2B, and the second line should be 2A. Why? Because we see the black arrow. These 2 black arrow actually pointed to the parametrium invasion. You see this lower signal rim here surrounding the cervix. Here also the lower signal rim, but disrupted by the tumor signal. And so here actually is the parametrium invasion. And so the answer should be 2B, 2B. And the lower lines, we see the intact low signal surrounding the cervix. And so these 2 are 2A. Okay, I think this is pretty much everything, and thank you for listening. Hopefully this presentation will give you some experience during your future clinical practice. Thank you.
Hello, this is Dr. Hong from Peking University People's Hospital. Today I will talk about lymphoma in the neurological system, spectrum of imaging findings. Lymphoma of the central nervous system consists of 2 major subtypes: secondary central nervous system involvement by systemic lymphoma. It is also the most common type. And primary central nervous system lymphoma, in which the lymphoma is restricted to the brain, leptomeninges, spinal cord, or eyes. The frequency of secondary lymphoma in patients with systemic lymphoma varies and is highly dependent on histologic subtype. The overall risk of central nervous system relapse in aggressive non-Hodgkin lymphoma is on the order of 2 to 27%, whereas patients with Hodgkin lymphoma are at very low risk. Primary lymphoma accounts for 1 to 5% of all brain tumors and about 1% of all non-Hodgkin lymphomas. Most cases of primary lymphoma are of B-cell type. Immunocompromised patients, for example, the patients infected with HIV, have an increased risk of developing primary lymphoma. The incidence rates of primary lymphoma are increasing among immunocompetent patients. For the clinical features, the clinical prodrome is relatively short, as most cases are diagnosed within 1 to 2 months after the onset of symptoms, and the presentation is determined by the location, the size of the tumor, and may include non-specific focal neurological deficits, behavior and personal changes, headaches. About 70 to 85% of cases involve the supratentorial compartment. In this case, there is a well-defined lesion in the left parietal lobe with marked enhancement on T1-weighted image with contrast. The lesion is iso-intense to granular on T2-weighted image and bright on DWI, indicating restricted diffusion, and the pathology was consistent with lymphoma. Focal intracerebral masses are the most common initial presentation of primary lymphoma, whereas the subarachnoid space is a common site for recurrent disease. Classic imaging findings of parenchyma lymphoma include solitary or multiple masses that involve the deep gray matter, periventricular regions, and corpus callosum. In this case, we can find several solid lesions in the left frontal lobe, which is iso-intense to gray matter on T2-weighted image, restricted diffusion on TWI, and marked enhancement on T1 with contrast. Predilection for the periventricular subependymal region, deep brain nuclei, and corpus callosum. In this case, the lesion involves the splenium of the corpus callosum with a homogeneously enhancing tumor with diffusion restriction at the splenium of the corpus callosum. In comparison with glioblastoma, which is also located in the corpus callosum, but with heterogeneously enhancing and has marked cystic necrotic changes. GBM. There is an infiltrative periventricular lymphoma, which also intense to gray matter on T2-weighted image and hyperintense on FLAIR images. Periventricular enhancement is demonstrated on T1-weighted image with contrast. Multiplicity is common and noted in about half of cases. Although meningeal involvement may be demonstrated in primary lymphoma, it is more common seen in secondary lymphoma. Primary lymphoma compromising the dural and adjacent bone. This patient presenting with frontal bulging for half a year. There is extensive dural thickening and enhancement in the left frontal region with less involvement of the right frontal region. The lesion extends through the bone to adjacent soft tissue where non-homogeneous enhancing is demonstrated. The tumor is also intense to gray matter on T2-weighted image. Intracranial metastasis from systemic lymphoma falls into two categories, leptomeningeal and dural-based. About 2/3 of patients with secondary lymphoma present with meningeal disease, including leptomeningeal, subependymal, dural, and cranial nerve involvement. Leptomeningeal seeding in absence of parenchyma involvement commonly escapes detection by computed tomography, but is easily diagnosed on contrast-enhanced MR imaging. Patient with secondary lymphoma presents with leptomeningeal disease characterized by enhancement along the cerebellar sulci in cerebellum. The multi-enhancing nodules are also demonstrated in the perivascular spaces bilaterally. In metastatic lymphoma to the central nervous system, it is exceptional for parenchyma masses to occur without meningeal involvement. Parenchyma masses usually represent hematogenous spread or growth of leptomeningeal neoplastic deposits. The patient had lymphoma in the left femur, presenting with headaches. On the MR study, there is a solid mass in the left temporal region, iso-intense to granular on T2-weighted image with restricted diffusion on ADC map. There is striking enhancement on T1 with contrast, which is also adjacent to the dura. For the CT and MR imaging, unenhanced CT typically shows high-density lesions in the central location that often reach or cross the midline, and the high cell density and the high nuclear cytoplasmatic ratio are responsible for their increased attenuation. And for MR, lymphomas tends to be iso-intense to granular on all MR spin echo sequences because of its high nucleus to cytoplasm ratio and relatively lower intratumoral water content. On non-contrast CT shows high-density lesions in the left parietal lobe adjacent to the ventricular surface, which is also iso-intense to granular on T2-weighted image. Lymphoma may be markedly hyperintense on long TR images. I'm finding usually demonstrated in intravascular and infiltrative lymphomas. This patient presenting with multifocal round nodule with high signal intensity on T2 and flare images in the region of watershed zones bilaterally and in the corpus callosum on the left. For the necrosis and hemorrhage. Hemorrhage and necrosis in an immunocompromised patient. This patient is HIV positive. There is a mass in the deep brain nuclei adjacent to the ventricular margins. The lesion is iso-intense to granular on T2-weighted image and presents with foci of low signal intensity on the gradient echo, consistent with hemorrhage. Enhancement is non-homogeneous. As the internal calcification, they are unusual in central nervous system lymphomas unless the patient received chemotherapy or radiation therapy. The extent of edema is generally less than that seen with primary gliomas or metastases of similar size. This patient is HIV positive, diagnosed with primary lymphoma. A large mass is demonstrated in the right hemisphere adjacent to the ventricular margins, displacing the midline. The lesion is predominantly iso-intense to granular on T2-weighted image and has no surrounding edema. Patient for compression demonstrated with GBM. Despite a smaller tumor compared with the lymphoma, more edema is demonstrated. About the contrast enhancement. The pattern of contrast enhancement is variable and may be as follows. The first is dense and homogeneous in most cases, and for the non-homogeneous or range enhancement, more common in immunocompromised patients because of high prevalence of hemorrhage and necrosis. It may also be seen in EBV-positive primary lymphomas. And the ependymal contrast enhancement. When enhancement is demonstrated along the ventricular surface, lymphoma should be considered. And also the detection of enhancement in perivascular space suggests lymphomas. Infiltrative and intravascular lymphoma may not demonstrate enhancement. So despite some characteristic conventional MRI imaging findings, it may be very difficult or impossible to distinguish cerebral lymphoma from other aggressive brain tumors. In this case, we can find a solid lesion in the left temporal lobe, which is hyperdensity on CT, isointensity granulometer on T2 weighted image, and restricted diffusion on DWI, and we also with marked enhancement on T1 weighted image with contrast. Brain enhancement in an immunocompromised patient. This patient diagnosed with SLE, presenting with headache. Brain-enhancing lesions are demonstrated in the frontal lobe and left parietal lobe on T1 weighted image with contrast. When enhancement is demonstrated along a ventricular surface, lymphoma should be considered. This patient with secondary lymphoma presents with leptomeningeal disease characterized by enhancement along the cerebellar sulci in cerebellum, and also multiple enhancing nodules are also demonstrated in perivascular space bilaterally. In this case, the patient with infiltrative lymphoma compromising the parenchyma adjacent to the left ventricular margin, the granule of corpus callosum, and the deep nuclei. Despite the minimal ependymal enhancement on T1 weighted image with contrast, the deep infiltrative lesion shows no enhancement. About the imaging characteristics on advanced MR imaging. Accurate preoperative differentiation between the tumors is important and proper treatment. Advanced MR imaging techniques such as diffusion-weighted imaging, diffusion tensor imaging, MR spectroscopy, perfusion-weighted imaging, and dynamic contrast-enhanced MR studies may also help distinguish lymphomas from other primary brain tumors. About the value of DWI. Studies have shown that apparent diffusion coefficient ADC can differentiate primary lymphoma from high-grade glioma. Lymphomas demonstrate low ADC values, a finding consistent with restricted water diffusion related to high tumor cell density. By contrast, high-grade glioma are relatively hyperintense to granulometer on trace DWI, and ADC maps consistent with elevated diffusivity. A very large mass is demonstrated in the left frontal lobe. The lesion is predominantly isointensed granulometer on T2 weighted image, marked enhancement on T1 weighted image with contrast, and presents restricted diffusion on DWI. Pre-therapeutic ADC tumor measurements within contrast-enhancing regions are predictive of clinical outcome in patients with primary lymphoma. Patients with prolonged progression-free survival (PFS) and overall survival (OS) had a significant reduction in post-therapeutic ADC values. This decrease in ADC measurements is suggestive of a net reduction of extracellular water molecular motion within treated lesions. Diffusion tensor imaging. DTI provide information on white matter integrity, and fractional anisotropy FA is a quantitative index correlated with the microstructural integrity of the myelinated white matter bundles. It has been reported that anisotrophy in tumors is affected by several factors, including extracellular to intracellular space ratio, extracellular matrix, tortuosity, and vascularity. FOA value is reduced in primary lymphomas up to 40% lower than that in the normal contralateral white matter, which does not occur in GBMs or metastasis. The mechanism that produces this reduction is an increase in the extracellular space secondary to tissue destruction. This is hyperintensity and deformity of the right corticospinal tract at the level of the internal capsule, with mild edema representing an isolated infiltration of the pyramidal tract. And on the 3D DT images reveals a marked reduction of the anisotrophy of the tract and delimitates the exact extension of the infiltration. About the proton MR spectroscopy. The spectral pattern of lymphomas of proton MR spectroscopy is similar to that of other malignant tumors and is characterized by increased choline, reduced MI, and prominent lipids. When lipids are demonstrated in solid-appearing tumors, lymphoma should be considered. Lipids are also typically seen in GBMs, but there they may be related to necrosis. This is a patient with lymphoma. Spectra demonstrate lower NAA, lower MI, and high choline, and prominent lipid to lactate peak, consistent with lymphoma. For the dynamic susceptibility contrast and dynamic contrast enhanced MR imaging, tumor neovascularization is absent in primary lymphoma, and thus they have lower mean relative cerebral blood volume or lower relative CPV max values and lower cerebral blood flow compared with GBMs. Because angiogenesis is not prominent in lymphomas, perfusion may not be elevated, which helps distinguish them from high-grade glioma. In this patient, there is enhancing lesion on T1 with contrast, but it does not demonstrate elevation of blood volume on relative CPV map and perfusion curve. If high cell density is suggested by ADC and no elevation of relative CPV is demonstrated, one should consider lymphoma instead of high-grade glioma. However, relative CPV of lymphoma may be higher, overlapping with that of high-grade glioma. In this case, ADC maps are valuable to distinguish these lesions because lymphoma shows significant restricted diffusion. This is an immunocompromised HIV-positive patient. There is a large non-homogeneous enhancing lesion in the right frontal lobe on T1 weighted image with contrast, with restricted diffusion on ADC map, and high blood volume on relative CPV map and curve from the perfusion study. GBM for compression. There is a non-homogeneous re-enhancing lesion in the right parietal lobe on T1 weighted image with contrast, with high blood volume on relative CBV map. However, as opposed to the restricted diffusion typically seen in lymphoma, high diffusivity is demonstrated in this GBM. Besides helping to distinguish lymphoma from high-grade glioma, relative CBV may be a potential prognostic biomarker in patients with primary lymphoma because lower values are associated with adverse prognosis. Patients with lower tumor-relative CBV values at pre-therapy baseline have significantly shorter PFS and OS compared with patients with high tumor-relative CBV values. Biologic correlates of relative CBV value in primary lymphoma remain conjecture, but one can postulate two possible explanations as to why low tumor relative CBV values may be associated with adverse outcome in patients with primary lymphoma. First, relative CBV value measure bulk vessel attenuation and thus reflect tumor angiogenesis. Second, relative CBV value depend on patent vessels for delivery of intravenous gadolinium contrast agent. Therefore, lower tumor relative CBV values in primary lymphoma may signify a relative lack of tumor angiogenesis or a hypoxic microenvironment and decreased patent vessels able to deliver intravenous chemotherapy to the tumor. Central nervous system lymphoma has generated great interest because of its rising incidence in immunocompetent patients and its responsiveness to systemic chemotherapy. Diagnosis of primary lymphoma is often suggested by its imaging appearance and established by biopsy because lesions are typically deep-seated in the brain and not amenable to resection. Furthermore, unlike other primary brain tumors, control of and survival from primary lymphoma does not improve with surgical resection. Corticosteroids are frequently administered immediately after the diagnosis of intracranial mass is made based on imaging. In 40 to 85% of patients with primary lymphoma, corticosteroids cause cell lysis and tumor regression. The speed of regression is variable, but complete disappearance may occur in 1 to 2 days. And some authors also report that complete regression at 8 hours after steroid administration. There is an ill-defined infiltrative lesion adjacent to the left ventricular, compromising the genial of the corpus callosum on the left and the deep green nuclei on FLAIR and titulated image, with cytosubepidermal enhancement on T1 with contrast. 4 months after the steroids, no tumor infiltration or enhancement is demonstrated on T2 and T1 with contrast. Before steroids treatment, there is a solid enhancing lesion in the left parietal lobe on T1 weighted image with contrast, and also with high perfusion on relative CBV map. Reduced perfusion is demonstrated after steroid therapy on relative CBV map. For the FDG PET-CT, primary lymphomas typically show marked inhomogeneous hypermetabolism with increased FDG uptake even greater than that of glioblastomas and metastasis. Basal ganglia and left external capsule infiltration by lymphoma evidence increased gadolinium uptake on T1 with contrast, and increased FDG uptake on PET image in the same area. About the differential diagnosis, high-grade glioma. Primary lymphoma often has solid enhancement, whereas GBM has an irregular and often rim enhancement due to a central necrosis. The less common forms of primary lymphoma with rim enhancement or atypical forms of GBM with solid enhancement would be hard to differentiate. In this situation, use of more advanced sequences such as ADC maps, MR spectroscopy for fusion, SWI, PET can be useful. Multiple sclerosis. Primary lymphoma can be misdiagnosed as MS in patients with non-enhancing periventricular lesions. The use of corticosteroids causes clinical improvement and regression of primary lymphoma in some patients, which may be interpreted as a steroid-induced remission of MS. Sustained clinical dependence on steroids is unusual in MS and should lead to consideration of primary lymphoma. Repeat central nervous system examination and gadolinium-enhanced MR imaging obtained without corticosteroids help differentiate between the two diseases. Despite enhancement may be demonstrated in acute MS plaques, if all lesion-enhanced lymphoma should be considered. Restricted diffusion may be demonstrated in some MS plaques, whereas restricted diffusion is typically seen in all lymphoma brain masses, usually matching the T2 abnormalities. In this case, multiple lesions are demonstrated in the corpus callosum and adjacent white matter, which resemble MS lesions. All lesions enhance, however, which makes the diagnosis of MS unlikely, and the final diagnosis is primary lymphoma. Tumor-effective demyelinating lesions, TDLS. TDLS are frequently encountered in clinical practice, and when they appear as solitary masses greater than 2 cm in diameter, they can cause symptoms mimicking brain neoplasm. Differentiating between primary lymphomas and TDLs by conventional MR imaging can be challenging, especially when they are atypical features in primary lymphomas. Valuable clues to the diagnosis is the vessel crossing the lesion, pattern of enhancement, and DWI measurements. For the vessels crossing the lesion, it is a linear vascular structure may be demonstrated within TDLs, indicating perivascular demyelination. In this case, there is a large mass in the right frontal lobe surrounded by extensive edema with high signal intensity on FLAIR image. Linear structures can be demonstrated crossing the lesion, suggesting vascular structures, indicating perivascular demyelination, TDL. A peripheral open ring of enhancement suggests a TDL, whereas solid enhancement suggests lymphoma. A peripheral rim of restricted diffusion suggests a TDL instead of lymphoma. This patient presenting with a right frontal lesion, which is hyperintense on T2 weighted image, with an open ring of enhancement on T1 with contrast, and a peripheral rim of restricted diffusion on ADC map. In this patient, there is also a right frontal lesion, which is isointense to gray matter on FLAIR, with solid enhancement on T1 with contrast, and restricted diffusion that matches the enhancing area on ADC map. So A peripheral rim of restricted diffusion suggests a TDL instead of lymphoma.
Multiple choice question. This is a 64-year-old woman with headaches and right hemiparesis. And the CT and MR images of this patient are shown here. What's the possible diagnosis? There are 4 possible diagnoses. The first is primary central nervous system lymphoma. The second is GBM. The third is tumor-affected demyelinating lesions, TDL. And the fourth is subacute infection. So let's take a look at the images again and what's the 4 possible diagnoses with primary lymphoma, GBM, TDL, or subacute infection. So let's take a look at the answer. The final diagnosis is primary central nervous system lymphoma. There is solid lesion in the left frontal lobe, which is hyperdensity on non-contrasted CT, isointensitogrammeter on T2 weighted image, and also with restricted diffusion on DWI. And also there is a marked enhancement on T1 weighted image with contrast. These are the typical findings of the primary central nervous system lymphoma. So the final diagnosis is primary central nervous system lymphoma.
In summary, when primary lymphoma is suspected, contrast-enhanced MR imaging is the technique of choice. Advanced MR imaging techniques such as DWI, DTI, MS spectroscopy, perfusion, and DC studies help establish a diagnosis of central nervous system lymphoma and distinguish lymphomas from other aggressive primary brain tumors such as GBM. If ADC suggests high cellular density and no elevation of relative CBV, consider lymphoma as the main diagnosis. Following administration of steroids, lymphomas may partially or completely regress. Restricted diffusion or ADC may resolve, and a previously hyperperfused lesion may demonstrate lower relative CBV. That's all. Thank you very much.
My name is Professor Vicky Go, and I would like to thank the European School of Radiology for inviting me to speak today on tumor response. These are the learning objectives. Following this lecture, participants will be able to list common therapies for cancer and describe mechanisms of action, describe common patterns of tumor response to therapy, and discuss the strengths and limitations of imaging response criteria. Cancer management has evolved in recent years with an increasingly personalized approach to care. Therapeutic options have expanded substantially, both for curative and palliative options. For example, for local regional disease, patients may now be offered surgery or ablative therapies, including radiofrequency ablation, transarterial chemoembolization or radioembolization, as well as radionuclide therapies and radiotherapy, while systemic therapy options include various chemotherapies, targeted therapies, and more recently, immunotherapies. And this is illustrated nicely in this slide, showing the range of therapeutic options for a patient with hepatocellular carcinoma, depending upon disease extent and liver function. with surgical resection or transplantation at one end of the spectrum and best supportive care at the other end. And all these treatments have an anti-cancer effect, but their mechanisms of action will differ. For example, with ablative therapy, the mechanism of action essentially of their anti-cancer effect is due to coagulative necrosis. This is due to the extremes of temperature from radiofrequency or cryoablation, or again, vascular occlusion from vascular embolization. DNA damage and reduction in cell replication rate is the mechanism of action with radionuclide therapies, radiotherapes, and also with chemotherapy agents. With anti-angiogenic therapies, the mechanism of action is essentially anti-vascular effect and vessel regression due to blockade of angiogenic factors. And with immunotherapy, essentially, the mechanism of action is via the enhancement of tumor-specific immune activity. And as a consequence, there are typical downstream changes in both tumor physiology and morphology. And these physiological changes, such as reduction in tumor perfusion, metabolism, and proliferation, often occur early after the onset of therapy and prior to changes in morphology, such as size, as seen here. And these changes may be detected as early as a few hours to a few days after the start of therapy, seen here in this patient with a stage 4 renal cancer, treated in a clinical trial with a combination of a vascular disrupting agent and anti-angiogenic. And here, dynamic contrast enhanced blood oxygen level dependent and diffusion MRI were performed essentially to assess changes in vascularization, hypoxic volume, and cell density, respectively. And in terms of assessing therapy, imaging has an important role to play. For patients undergoing definitive or local regional therapy, imaging can define if treatment was successful, as seen here in this patient undergoing transarterial chemoembolization. And this post-therapy CT, both the arterial and the portal venous phase images demonstrate the distribution of iodized oil within the lesion. Imaging may also provide a baseline against which future assessment can be compared to detect suspected treatment recurrence, and imaging may also demonstrate any sequelae related to treatment, such as shown here on this slide. This is a patient with a hepatocellular carcinoma treated with stereotactic body radiation therapy, and one can clearly see on the post-therapy scans on the bottom row the demarcation between irradiated and non-irradiated liver, and also the hyperemia on the arterial phase imaging associated with the inflammation within the irradiated normal tissue. For systemic therapy, imaging can establish if there are any changes in disease burden, and again, identify if there are complications related to therapy. So here an example of a patient with progression of disease despite treatment. And in terms of the choice of imaging modality, this will of course depend on the disease extent, the site, as well as the therapy being assessed. And depending on whether it's local, regional, or systemic therapy, there are numerous clinical guidelines that can advise on this, as shown here. So when assessing therapy, as radiologists, we've traditionally defined response in clinical practice by the changes in tumor morphology, but more recently also as a likelihood of response. So for example, for the liver, LIRAD's tumor response, for example, has been proposed to define certainty of tumor viability or non-viability. And this has been shown in subsequent studies to have a good performance in distinguishing non-viable from viable lesions, particularly the absence of enhancement in the arterial phase. Another example, rectal cancer. Here, a tumor regression grade score has been proposed, shown here, where a score of 5 represents a poor response, and a score of 1, as seen here, represents a complete response to neoadjuvant chemoradiation. Here, another example showing good response with mixed areas of fibrosis and tumor, as well as the sequelae of radiotherapy. And such response assessment has been shown to have prognostic value in terms of both overall and disease-free survival, as shown here in the Mercury study. And moving on to the context of clinical trials, objective response criteria have more typically been used. Here in phase 2 and 3 trials looking at drug effectiveness, imaging objective response criteria act as an important trial endpoint. And the rationale really for using these objective response criteria is that they do standardize the classification response and are much more reproducible than other more subjective assessments, as well as reflecting, importantly, clinical outcome. Of the response criteria, RECIST, response evaluation criteria in solid tumors, is the most widely used for response assessment. Here, response is based on changes in measurable disease, specifically specified target lesions, though non-target lesions which remain measurable, as well as new disease, are also taken into account in response categorization. Just to illustrate this further, for target lesions, complete response is defined by disappearance of all target lesions, and when nodes are now all less than 10 millimeters in short axis, in other words, non-pathological. Partial response is defined by a greater than 30% decrease in the sum of lesion longest dimensions. Progressive disease by greater than 20% increase in the sum of lesion longest dimensions or the development of new lesions. And stable disease is defined when there's neither a partial response or progression of disease. For non-target lesions, complete response is again defined by the disappearance of all non-target lesions and nodes remain non-pathological. Progressive disease by unequivocal progression or the development of new lesions, and non-complete response, non-progression by the persistence of one or more target lesions. And here is just an example showing baseline cycle 2 and cycle 4 therapy CT images. And here the target lesion was a liver lesion in segment 7. You can see here, due to the changes of greater than 38% in the sum of the target lesion from baseline, that this was a partial response of the target lesion and a persistence of the non-measurable disease sub-centimeter liver metastases. Here, another example, this time progression disease. Here there are 2 target lesions within the liver, and this is a 27% increase from baseline at cycle 2. And therefore, this is progression of disease. You can also see that there is a splenic metastasis non-measurable, which is persisting. And this is just a nice example. Of course, while RECIST remains the most widely used response criteria, nevertheless, it has its limitations. First, disease at certain sites may not be best reflected by single measurement, as in the case of thoracic tumor mesothelioma. Second, response in highly vascular lesions may also not be best reflected by measurements in the portal venous phase, typically when these lesions are measured, because they're less distinct, as in the case of hepatocellular carcinoma. And this has resulted in modifications to existing RECIST criteria, as shown here for HCC, where lesions are now measured in the arterial phase. There are also limitations of RECIST for certain therapies. It may underestimate response, for example, in the case of anti-angiogenic therapy, which is cytostatic rather than cytotoxic. And here trials have found a dissociation between objective response and clinical benefit, with a larger proportion of patients demonstrating stable disease rather than partial response, yet continuing to benefit from drug in terms of outcome. And this has led to alternative criteria being proposed as listed here, including the Chen, Choi, Modified Choi, and MASS criteria, taking into account changes in vascularization and other morphological factors in addition to size. And here is just an example, stage 4 renal cancer treated with a tyrosine kinase inhibitor, showing stable disease by RECIST and also by modified Choi and MASS criteria, but obviously a partial response by Choi criteria. Furthermore, with immunotherapies, these using antibodies targeting these co-inhibitory signals, thus enhancing T-cell anti-tumor activity, different patterns have also been seen, identified in response to therapy in clinical trials, including the pseudoprogression in approximately 10% of cases for both morphological as well as functional response assessment, where we see either a transient increase in the size of lesions or regression of existing lesions, but the development of new lesions. And this is illustrated nicely here in this figure from this article, where you can clearly see the concept of the transient increase in size of the target lesion with pseudoprogression, as well as this pseudoprogression, regression of target lesions, yet transient development of new lesions. And this has led to immune response criteria being proposed also, both for standard imaging as shown here, as well as for molecular imaging, requiring confirmation essentially of progressive disease within 8 to 12 weeks, depending on the criteria. So 4 to 8 weeks for iRECIST, but 4 to 12 weeks for IR-RECIST. So with this in mind, let's have a look at a few case examples. So here is a first case. So let's have a think now about what you would designate as target lesions, non-target lesions, and non-measurable disease. So looking at these images, what would you designate as a target lesion? Please select as many as you think from the list below as you would deem correct. Would this be a liver lesion in segment 2, 4A, or 7, bone metastasis, mediastinal nodes, or left breast lesion? As you see, these would be the correct answers, A, B, and F. The liver lesions in segment 2 and 4A, both measuring greater than 1 centimeter, and a left breast lesion. And just to reiterate, essentially, in terms of designating target lesions, these are actually lesions that should be selected from different sites, be reproducibly measured. The tumor should actually be greater than 10 millimeters in longest dimension, nodes greater than 15 millimeters in short axis. There's a maximum of 2 per organ and a maximum of 5 lesions. And anything that remains measurable, but beyond this, essentially target lesion exceeding this number, would be designated as non-target lesions. So with that in mind, what would you now designate from these images as non-target lesions? And again, please select as many as you would deem correct. So you will see that essentially this should be the liver lesion in segment 7, which is greater than 1 centimeter. And moving on now, just to remind you again, non-target lesions, measurable lesions, these are lesions that remain measurable when the number per organ or per patient has been exceeded, and with those measurements in terms of the longest dimension and short axis. Now, what would you designate as non-measurable disease? Again, please select as many as you would deem correct. Would it be the liver lesions, bone metastasis, mediastinal nodes, or left breast lesion? Here, the correct answer is, of course, D and E, as shown here. And just to remind you, non-measurable disease by RECIST are essentially those lesions which are less than the size designated for target lesions, or other non-measurable factors like effusions, ascites, lymphangitis, osteoblastic bone metastases, inflammatory breast disease, or leptomeningeal disease. So looking at response now in this same patient, if we now focus on the target lesion and the response after cycle 3, the images seen in the middle row, and cycle 6, the images in the bottom row. If we look first at cycle 3, please choose what you think the response would be from the measurements given at cycle 3. Would it be a complete response, partial response, stable disease, or progressive disease? So after cycle 3, looking specifically at the target lesions, this would be a partial response, as there is a 48% reduction. So this is above the threshold, which is greater than 30% reduction. If we now have a look at what the target response should be after cycle 6, again, would you select complete response, partial response, stable disease, or progressive disease? And again, correctly, this should be partial response, as the percentage change from baseline is now 52%. So in terms of just the target lesion alone, this would still be a partial response. But what if we now have a look at the non-target lesion response after cycle 3 and cycle 6? Would you consider this to be a complete response, non-complete response, or progressive disease? So after cycle 3, we would say that this is non-complete response due to the persistence of the lesion. And in terms of after cycle 6, and the same 3 choices again, you will see here actually that the response, instead of being a non-complete response, is actually progression at this stage. And this is due to the increase in size of the non-target lesion. So next, if we now have a look at the overall response, taking into account target lesions and non-target lesions after cycle 3 and cycle 6, how would you designate response assessment? Would it be complete response, partial response, stable disease, or progressive disease after cycle 3? And so if we look at the changes in both the target lesions and non-target lesions, we would say that after cycle 3, that this would be a partial response. Moving on to cycle 6, and the same 4 choices again, what would you now consider if you take the overall response, taking into account both target lesions and non-target lesions? So again, we're seeing that overall response here would be progressive disease, and also due to the presence of new lesions. So that would be the correct response. And we now look at the best overall response, taking into account time point 1 and time point 2, what would be the best overall response? And the answer here, the correct answer here, is B, partial response. So the nadir was at the time point 1 following 3 cycles of therapy. Moving now on to case number 2. So this is a case of a metastatic renal cell cancer treated with the tyrosine kinase inhibitor sunitinib, targeting the following: VEGF, PDGFR, c-KIT, and RET. So with respect to RECIST 1.1, how would you measure this target lesion? Would you measure longest dimension, short axis dimension, or you can also say don't know? What would your choice be in this case? Please select an answer. So the correct answer was B, short axis, as this is a nodal mass. So next, if we now look at what response there was with respect to RECIST 1.1 following 2 cycles of therapy, we see now that there has been a reduction in the short axis dimension from 4.7 to 3.5 centimeters. So this is a 25% reduction in target lesion. What would be your selection? Please choose an answer from the following. Would it be complete response, partial response, stable disease, or progressive disease? So the correct answer here would have been stable disease. So the reduction is below 30%, and this is the typical appearance that you would see with a lesion being treated with a tyrosine kinase inhibitor. And just to show you the proforma for completeness, you see here that the response here is stable disease. There were no new lesions, and the best response was stable disease. Moving on now to case number 3. This is a case of a hepatocellular carcinoma, and this was a patient treated with sorafenib. You have the baseline images here, as well as the images following 4 cycles of therapy. So if we're having a look now at modified RECIST criteria, with respect to modified RECIST, what do you think the response to therapy is in this patient, giving those measurements taken in the arterial phase into account? Was this a complete response, partial response, stable disease, or progressive disease? Please select an answer from the following choices. So The correct answer here was progression, as there was an increase in baseline of 24%, which is above the 20% threshold. And now moving on to another case, case number 4. This is another example of a metastatic renal cell cancer treated now with pazopanib, which targets VEGF receptor 1s, 2, and 3, PDGFR alpha, beta, and as well as c-KIT. So this is a lesion that after cycle 2 decreased in size by 42% and enhancement by 74%, from 78 to 20 Hounsfield units. So if you're now looking at response by the modified Choi criteria using these arterial phase images, would you think that this was a complete response, partial response, stable disease, or progressive disease? Please choose a response from the list below. So the correct answer was B, partial response. And just to reiterate, and this is because partial response is defined by a decrease in size of 10% or more, as well as the enhancement reduction of 15 Hounsfield units or more on arterial phase imaging. We did not use Choi or mass criteria here because the images were obtained in the arterial phase and not the portal venous phase within the thorax. And moving on to a final case, case number 5. This time we're looking at metastatic bladder cancer that was treated with the immunotherapy pembrolizumab. So with respect to the immune response criteria RECIST 1.1, what is the response after 3 cycles of immunotherapy? So you can see the pre-therapy, post-cycle 3 there, and end of study images there. Was this a complete response, partial response, stable disease, or progressive disease? Please select an answer from the list below. So as you can see, this was a complete response due to resolution of the lesion there on cycle 3. And again, with persistence, this response was maintained at the end of study imaging. And just to remind you again of the different immune resist criteria. So this was basically resolution of the target lesion. So this was a nodal recurrence, and this was basically resolved by the end. So this was actually a good response to immunotherapy. So of course, just as a reminder, the immune response criteria, of course, developed in order to take into account the concept of pseudoprogression. So this is the end of the cases. And in summary, imaging assessment of treatment is an important aspect of cancer management. Following definitive treatment, imaging indicates if residual disease or complications are present and provides a baseline against which future assessment can be compared. The change in tumor burden is an important aspect in the clinical evaluation of cancer, as well as an endpoint in clinical trials. Importantly, response criteria provide objective, standardized, and reproducible evaluation of response in clinical trials. While RECIST 1.1 is most commonly used, it has recognized limitations, including suboptimal assessment at certain body sites or tumor types. It may also underestimate effects of targeted therapies such as anti-angiogenics, and modifications of RECIST 1.1 may provide more relevant information of effect, for example, with immunotherapy response criteria. And with that, I would just like to say thank you very much for your attention.
Thanks all speakers, bring us excellent talk. Let's move on to the question and answer section. Because we're out of time, we will shorten the Q&A section. The first question is for Professor Fortner. The question is how to evaluate lesions in central zone. Thanks.
Thank you. This is a very interesting question. It's also a very difficult area. Only 1 to 2% of the lesions are located, of cancer are located in the central zone. And if you look at the PRIMERS classification system, it's mainly focused on the peripheral zone and the transition zone. In general, we use the criteria for the transition zone, also for the central zone. So in other words, it can be quite difficult. We always look at asymmetries because most of the central zone the normal central zone is like a mustache, and if there's early enhancement or abnormal enhancement and asymmetry, most of the cases are positive for cancer, but there's a very low chance. Most oftenly, it's growing into the central zone, from the peripheral zone into the central zone, or from the transition zone into the central zone.
Thank you so much.
Thank you.
The next question. Thank you. The next question is for Professor Huadan Xue. Do we have any anatomy structure to divide the vagina into 3 parts? Thank you.
Truly, there's no structure to divide the vagina into 3 parts. You just measure it and then you cut it into 3 parts. That's straightforward. Thank you for the question.
Thank you. The last question is for Professor Gong. Do you use the RECIST criteria in the clinical setting as well, or just for patients enrolled in clinical trials?
So thank you for this question. Of course, RECIST and other response criteria have been developed specifically for clinical trials. But I think, in my personal opinion, actually having the schema in your head and having discussions with your oncologist as to whether this is something that they would appreciate is actually relevant and useful, because essentially what it does is it gives a much more objectivity and also standardization across your colleagues as well in terms of reporting. And so it's something I would encourage you to consider in your practice. Thank you very much.
Thank you. All schedules is finished, and I appreciate all speakers and audience participant the ESOL International course today. Also thanks hosts and all supports from ESOL. All audience were encouraged to evaluate the course, and it is helpful to improve the ESOL course. And last, I also released a good news. All lectures can be reviewed again in 3 months. The schedule is over. See you next time.
Thank you very much.
Thank you, all of us.
Thank you.
Thank you.
It was a pleasure.
杨老师辛苦
Very nice
了。
to meet you all.
应该的，您辛苦了。